Before we look at each of the functional spheres of the psyche, we should get some more groundwork in. Let's start with pathological mental phenomena in general, because they may differ in their structure, origin, severity, duration, and in the way they alter a person's experience of themselves and the external world. For this reason, we should approach them with different clinical distinctions and conceptual frameworks that help describe, differentiate, and interpret them. First category of distinctions I want to look at is that of etiology, or cause. Some conditions emerge during development while others are acquired later in life. For example, intellectual disability is a developmental condition, while dementia is acquired later in life. Certain symptoms may arise as understandable reactions to external events or stressors, whereas others appear relatively autonomously. For example, we can see acute stress reaction or an endogenous depression. The last criteria we have to cover here is that of broader etiology. Endogenous disorders can be understood as illnesses emerging from internal biological predisposition or constitutional mechanisms without obvious external causes, while exogenous disorders are conditions resulting from identifiable external influences affecting brain functions. For example, intoxications, trauma, infections, and so on. In reality, we know that many psychiatric conditions involve interplay of internal vulnerability and external factors. Despite that, this distinction still remains useful conceptually, even if modern neuroscience has complicated its boundaries. Next category I invite you to look at is that of temporality, to see how psychopathological disorders and symptoms may differ in their course over time. Let's start with distinction between acute and chronic. Some disturbances may appear suddenly and resolve rapidly, while others may persist chronically and even progress over time. To illustrate this better, we may see a patient in a state of drug-induced psychosis, which is an acute condition, or we may be dealing with a person suffering with paranoid schizophrenia, which is a chronic condition. On the other hand, some conditions and symptoms may occur episodically with periods of remission, while others follow a continuous course. For example, bipolar disorder, which can be described as episodic, while persistent depressive disorder is continuous. Pathological phenomena may also be reversible or irreversible. They may present as transient states or enduring traits of personality and functioning. Symptoms and disorders may also differ in their structure and severity. They can be stable and non-progressive, like intellectual disability, or we may see progression over time, or progradients. This we would see in neurodegenerative disorders, for example, and more specifically in dementia. Now let's discuss symptoms themselves. Certain signs and symptoms may be highly characteristic, central, or even pathognomic for specific psychiatric conditions. We would call them obligatory. Others that are non-specific and occur across different conditions are termed facultative. For example, hallucinations alone do not indicate schizophrenia, since they may also be present with affective disorders, intoxications, delirium, neurological conditions, and so on. Symptoms are not always equal in diagnostic significance. Some represent direct manifestation of the underlying pathological process, while others develop secondarily as a reaction, consequence, or psychological response. For example, a patient experiencing auditory hallucinations may subsequently develop fear, suspicion, insomnia, or social withdrawal. In this case, hallucinations are primary symptom, while the rest is secondary. Let's take another example. With persecutory delusions, where a person thinks that his enemies are after him, he may subsequently develop anxiety, irritability, social withdrawal, or even aggressive behavior. Psychopathological symptoms may reflect either a change in the intensity of normal mental functions, like their increased or decreased activity, which we call quantitative changes. For example, elevated or depressed mood, increased or decreased motor activity, and so on. Or we may see transformation in the quality and structure of mental experience itself. This we call qualitative disturbances. For example, hallucinations and altered states of consciousness. Another important distinction is between positive and negative symptoms, which are classically associated with schizophrenia spectrum disorders. I've included them here since they can help us better conceptualize what can happen to normal functioning of the psyche. Positive symptoms represent the addition of pathological phenomena that are normally absent or distortion of normal psychic functioning, such as hallucinations, delusions, thought disorganization, and so on. Negative symptoms represent a reduction, loss, or impoverishment of normal psychic functioning. This includes emotional blunting, avolition, social withdrawal, reduced spontaneity and motivation, and so on. Another important thing to keep in mind is that positive symptoms often appear more dramatically and are more clinically visible. For example, psychomotor agitation is readily visible, while negative symptoms can be more subtle and so gradual that they may even go unnoticed prior to causing functional disability. Let's illustrate this gradual onset of negative symptoms with an example. Imagine a person slowly becoming more passive, more distant from family and friends. Over time, he may even quit his job and become totally secluded. He may even lose interest in his favorite hobbies and activities. We pretty much covered the basics I wanted to talk about in terms of conditions and symptoms, and it's time to introduce one of the key distinctions in psychiatry: neurosis and psychosis. These are very loaded terms, and psychologists and analysts can spend hours talking about them. Fortunately, for the purposes of our lectures, information provided on the slide is going to be enough. Two key elements I want to focus on are reality testing and insight. Reality testing refers to the ability to objectively evaluate one's thoughts, feelings, and perceptions against the actual external world. In neurosis, this ability works properly, while in psychosis, its functioning is disturbed. To put it simply, psychotic patient loses touch with consensus reality. Instead, they experience non-consensus reality or altered reality. When I say consensus reality, I mean the version of the world that most people can agree on is happening. The second criteria is that of insight, and it is also very important. While patients suffering neurosis understand that they are experiencing symptoms, psychotic patients, due to disorganization of psychical functions and impaired reality testing, may not have the capacity to grasp that what they are experiencing are symptoms of an illness. For example, they may take hallucinations that they perceive as a part of external world. So, with neurosis, we're dealing with disturbances within reality, while psychosis is a disturbance of reality. This was it for the introduction. The material we covered here should give us a solid ground to stand upon when in the next lectures we'll move to the arbitrarily divided parts of the psyche. Thank you for listening.